welcome all. I'm going to mute you so we don't have any distracting noises. You can all unmute yourselves when you want to make comments, but I'll ask you to please remute once you've made your comment. Tonight we're going to go through the beta of Disaster Medical Operations 1 and 2. This is the new Contra Costa County revisions for the FEMA deck. When we present in the classroom, it takes us about 5.5 hours. We're going to try to do it all in about 1.5 hours. So we're going to skip a lot of material. I'll just gloss over it. Mostly this to show you what has changed, because you have all gone through the class, and so we just have some changes, some changed focuses primarily. So I'm going to share my screen, and here is one. I trust you can all see that. Okay, so we keep changing the name of our group. We used to be C8, then a month ago we were the XCC CERT Coalition. XCC because every operational area in the state, meaning every county, has an X code. So Contra Costa is XCC. But we figured not enough people would know what that was, so we're just going to go CCC CERT Coalition as the new name for C8. C8 was confusing because nobody knew what it was, and when they heard that it was the Contra Costa County Citizen Corps CERT Committee, they thought that it was all the teams in the county. Well, not all teams are active in it. So anyway, we said to just go with the CCC CERT Coalition. So you'll see that, unless it changes next week, you'll see that going forward. So we're terming these units Disaster Medical Operations. That's a new term, but find on this computer my mouse, and here we go. So the standard screen for every slide deck. This is the update as you've seen in the last few months. We've updated to this, adding the communication device and some things like have water and so forth. So the unit objectives, we're going to identify the 3 killers, talk about airway, breathing, shock, so forth, but I am going to skip through this quickly. So death from trauma comes from overwhelming and irreversible damage to vital organs. That's why we want to prevent these things from happening right away. That's what we're looking for. So 90% of disaster survivors are rescued by other survivors. So that's us. So we're teaching you how to do this. Personal protective equipment, in class would go through it a lot. Showing vents, this is all new since COVID. We are now focusing on the vent masks and staying away from them. They're good in wildfires, but they're not good for bacteria. Little video on how to put on and take off a mask, N95, which we'll skip. How to put on and take off surgical gloves. Again, it's a video, you notice by note copyrighted material, so we're looking for a new video to replace it, teaching you how to take off your gloves without getting it on you. Okay, so the killers we talked about, airway obstruction. excess bleeding, and shock. These are the three things that we look for immediately and address as quickly as possible. If you have any questions, don't raise your hand because I won't see you. Just unmute yourself and jump in and ask. So, how to approach a patient? First, size up the scene, make sure that everything is safe. Make sure the patient can see you, identify yourself. Nothing here has changed. On the unconscious patient, again, nothing's changed. You have implied consent. You tap and shout to make sure that they are unconscious. Make sure that their airway is open, and then you proceed to view the unconscious patient and to look for the chest rise, so forth. Opening the airway, nothing's new here. Going through practice, then we talk about bleeding, the different kinds of bleeding, the spurting, pooling, soaking. And I just changed this to a different computer about 15 minutes ago because Zoom on my main computer locked me out today. So some of the graphics may not fit here. Like this one is a little tight, but it will be better. So direct pressure, we have eliminated the elevation. That's not part of FEMA anymore. We don't elevate the part, and we're not teaching pressure points anymore. So it's just direct pressure. What we are teaching now is we're talking.
Duncan, what do we tell them if direct pressure doesn't work? What are we telling them? What's next?
Well, if direct pressure doesn't work, then if it's on a limb, they go to a tourniquet.
I don't see that here. Oh, I just see it now. Okay, never mind. Sorry. Yep.
Yeah, this slide is all about tourniquets. So, but of course, they're only good on limbs. So if you have a bleeding source that doesn't respond to direct pressure that's on the torso, then we tell them to take a Stop the Bleed class and learn how to pack wounds. But of course, wound packing is only good in junctional areas, shoulders and hips. It's not good on the torso. So you just have to apply pressure. So we go more into tourniquets, and we will actually have practice tourniquets, and we will teach people how to use them. How to make an improvised tourniquet, so forth. We plug the Stop the Bleed program, and we will be offering the class as soon as we can get in person, because you really can't do a Stop the Bleed class without being in person and touching. So we'll have a tourniquet demonstration and then the video, which we won't show here because of time. Okay, we go into talking about shock, which again is a killer. So result of ineffective circulation of blood, leads to death, and then we talk about the type of shock from blood loss from the heart not pumping and infection, septic shock. Signs of shock. This is one of our CERT volunteer victims that Julie made up. She moulaged him and took the picture. Anyway, we go through all the signs of shock. All of these signs for the different conditions are the latest CDC or wilderness medicine signs. If they conflict with FEMA, we took the medical professionals' word for it over FEMA. So some of the things here are not in total agreement with FEMA. Shock treatment, getting into the recovery position, we're about to photograph a 2-person movement into recovery position. We have one person on our team who's really adamant that the recovery, we have to do everything as a team, so we have to rephotograph everything with team members. But 2 rescuers if possible, and check for breathing before moving on, so forth. Nothing has changed here. We define an MCI, multi-casualty incident. And then we give some examples. I have a whole doc on the top of my screen, so I can't see the headers. But anyway, these are the different things that can happen anywhere. Because we're teaching all hazards, we include tornadoes and hurricanes, even though we don't have hurricanes here. People might be traveling and be exposed to them. They know about them, so we're teaching for all hazards, so we include them. CERT Size-Up, this is the standard size-up, nothing has changed here. We do talk in preparedness about doing more of a size-up and doing a situational awareness, but then when it comes to the actual event, we do a standard CERT Size-Up. Triage. This is an interesting area. In the newest FEMA materials, the 2019 FEMA slide deck release, they eliminated triage from medical. There was so much kickback that now they have added it, saying that they're not presenting it, but individual CERT teams can teach the version of triage that they like, because there are 5 different kinds of triage, 5 different systems. So we're still teaching the start and jumpstart triage just like we always have. So it's start for adults and jumpstart for kids. Because Contra Costa medical director, I have to update the slide. The Contra Costa medical director has said that we are no longer using the categories, we are using only the colors. So we're not going to say minor, intermediate, delayed, and deceased. We're only going to refer to patients as green, red, yellow, and black. So this has to be updated. Only the colors are being used. So nothing has changed in the way we teach triage. Pitfalls, the greens, nothing has changed here. We are focusing on the 32 can do. We want people to remember that. We want them to remember that RPM leads directly to 32 can do. So it's a mnemonic that people can easily remember. Children, again, we've taught this in the past 3 or 4 years. People before that people who took CERT before that may not have seen that children are faster. They have a bigger range than adults. Adults can be anything up to 30. Children can be 15 to 45. Infants can actually be much higher. Infants can go up to 60. So again, we're going through the RPM, R for respirations. So we highlighted the 30 and the 32 can do. P for perfusion, under 2 seconds. Again, the purple 2. So we're really focusing on that 32 can do. And the mental status is the can do. So black, of course, deceased, the morgue or the non-salvageable. There are many, many terms, but we're using the black, and we will get rid of the deceased. The red, yellow, everything's within limits for the yellow. They can have broken bones, they can have lots of things, but they're not life-threatening injuries. We go and show that video, you probably all remember it. It's the video with the bus on its side, where the firefighter goes through and triages everyone. So we're just reviewing triage, and then we do an exercise. And anyone who's taken CERT in the last 5 years or so in La Miranda did this exercise. So that was module 1. That is a night in class with all the exercises, but we showed it pretty fast there. Are there any questions about it? Hearing none, I'm going to share another screen. And this is Disaster Medical Ops, Part 2. Here we have more changes. This is the standard slide. So unit objectives, if you'll notice, we start out every module now with the unit objectives, and then we end the unit with unit takeaways. So that's something that we've done just as a standard format issue. So we're assuring personal protection, protecting public health, so forth. These are, we've talked about them before, but we're making them more essential. We're talking more about some of these things, like protecting public health is with sanitation measures. Because of the pandemic, everyone's awareness is heightened about things like sanitation measures. So we're being more focused on that. Okay, so frequently sanitize hands. This is your own hygiene. talking about area sanitation, medical waste, which we haven't covered very much in the past. What do you do with it? You put it in red plastic bags, you tie it off, mark it, and sometimes you have to leave it on site if you don't have anything else to do with it. If it's human waste, you bury it. Talking about drinking water, and drinking water, of course, is the same disinfection as the water you would use for cleaning wounds. If you don't have anything cleaner, this is how you would get the water to wash your hands, clean wounds, and so forth. This is an old slide, an old picture. So we maintain proper hygiene, proper sanitation, purify the water if necessary. We prevent the spread of disease. In determining our treatment area, we determine it and then we cite it. This is all old stuff. We haven't updated anything in the citing. It's upwind and uphill. You probably recognize the head-to-toe assessment forms. Those are longer-ended forms. And these are our life-threatening injuries that require immediate treatment. So, head-to-toe assessment. We're determining the type and extent of injuries and figuring out what needs to be done for the patient, monitoring the patient and documenting changes in their condition, documenting everything we've done for them, and we tag everybody. So we look to all survivors, even those who appear fine. We go through the head-to-toe assessment. Nothing has changed in the starting. We ID ourselves, get permission, protect privacy, so forth.
Hi, I'm Captain Stacy Garlick. I am the commander.
And that's the CERT head-to-toe video. We're hoping to reshoot that locally, but it works. There's nothing wrong with the video. It's just not as nice a video as we hope to be able to produce if we have time this summer. So we go through the whole process of the head to toe, talk to the patient, become aware of mechanism of injury. We haven't pointed this out in the past, but we're now making it a bullet point because mechanism of injury is on the form, and it's something we really want to get the people to look for. How did the person get injured? Children assess toe to head. Be systematic, so you're working the same system, the same routine every time so that you don't miss something. Score your pain 0 to 10. There are lots of ways of scoring pain. We've just adopted a 0 to 10 scale because it's easy for patients to tell us in that sort of terms where their pain is. On the hands-on assessment, we're going to start doing more with the DCAP-BTLS. We've shown it in one slide in the past. We've taken a few seconds to talk about Injuries-DCAP-BTLS, and I'm sure that nobody remembers it. So we're going to change that. So we're checking our gloves for patient's blood and check circulation, sensation, and motion in all extremities. We're focusing more on CSM because we want people to, once they bandage or sling or do anything to an extremity, we want them to recheck for circulation, sensation, and motion, CSM, at the end of all operations. So we look first for the killers, then look for head and neck injuries, then any other injuries. So head and neck, spinal injuries, this is what you're going to look for: the diminished consciousness, inability to move, uninjured body parts, low to the head, so forth. This hasn't changed. So in the head to toe assessment, we're stressing now the communicate. We want the rescuer or the evaluator to talk to the patient, communicate to him, and have an open dialogue with him, and try to get the patient talking as much as possible, because you learn a lot about what's going on, and you can take a patient's history while you're doing the head to toe if you get them talking. So now we go into DCAP-BTLS, which we never tried to get anyone to remember in the past. So we're going to start talking about deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling, all the things that you should be looking for. So DCAP-BTLS is just the mnemonic to make you remember what all to look for. So that's a deformity. Obviously, the wrist is not supposed to look like that. Oh, well, I apologize. This old computer doesn't do the transitions. This is supposed to flow from one screen to another, so I'll have to rework it and make sure it works on all computers. Contusion. This is someone's lovely grandchild who fell and bumped his head. Has a nice contusion. Abrasion. And a puncture. Burns, tenderness, laceration, and swelling. And again, for some reason, all the formatting is not working on this computer. So I'm going to have to make sure it's all universal, that it works on all computers. And then we go into a DCAP-BTLS practice. So we'll break out into small groups and practice finding all of these injury types. Haven't quite figured out what that practice is going to look like yet, but somehow we'll create a practice, probably with more photos and have people identify them.
Duncan?
Yes.
Hi, sorry, it's Dave from Martinez. When you say this example, this exercise, are you doing a whole head to toe?
Correct.
Okay, got it.
Yeah, but these are just the things to look for in the head to toe.
Right. Okay.
So we've already gone through the video with the head to toe, so we've we've already done that. So now we're just looking at the different things that we look for in the head-to-toe assessment. Okay, so we went through DCAP-BTLS, then we go in and look more intensely at burns. So what are the sources of burns? Heats, chemicals, electricity, radiation. And then we talk about the burns in the first, second, and third degree of burns. And how do we treat burns? Get them away from the burning source and cool. And cooling burns is a delicate subject because you don't want the person to go into shock or into hypothermia if you cool them too fast. So we'll be covering more of that by talking about the rule of nines. In La Miranda, we had the rule of nines showing adults and kids. Everything is changing a little bit. We used to say don't cool more than 1/9 or the 9%, 1/11 of the body, 9% at a time. The new recommendation is to not cool more than 5% at a time. So half of one of these sections, like half of the chest front, is allowed to be cooled at one time, so forth. Or the thigh, but not the calf, because together they're 9%, so forth. So you do 5% at a time to prevent hypothermia and shock. Yeah, we had images of children and infants with the different percentages, but we pulled those because it was just getting to be too much detail for people to remember. Basically, it's the head is the largest part on an infant, and as they grow larger, the head in proportion decreases in proportion from 21% in an infant to 11 or to 9% in an adult. And in children, the torso takes a while to grow, so the legs are a greater percent in a young kid than the torso, so forth. But you just have to remember, essentially, don't cool anything that is too large at a single time. If it's bigger than the palm of their hand, don't cool it. As the palm of their hand is the guideline for how much to cool at a given time. Again, this is old material, no antiseptics, ice, ointments, butter, so forth. Don't break the blisters. Use extra caution in frail, elderly, and young. Anyone who's more who has a lesser immune system and can more easily be damaged by injury. Be very careful with. Okay, chemical burns. This, the illustration there is over some type. I'm sorry about that, but again, that's the computer screen. So when we're treating chemical burns, and this is newly stressed material, wear PPE and do a situational size-up. Remove the cause of the burn. Brush it away gently, away from their eyes, away from the patient, and away from you. And then use lots of cool running water. Of course, cool running water is, if you have a lot of water, use it. But there are some things that you don't want to use water on. Water just makes them worse. So we have to figure out how to talk about those, how to talk about identifying the powders that you don't want to use water on. That's why it's still beta. We still have to figure that out. Inhalation burns, nothing's changed here. Even the photo hasn't changed. In wound care, the objectives are the same: control bleeding and prevent secondary infection. And we irrigate, don't scrub, no hydrogen peroxide. Nothing here has changed. What we're doing now, though, is we're talking about the differences between what a dressing is and what a bandage is. That's, well, we've talked about it in the past. It's always been a question that a lot of people still have. What's the difference between dressings and bandages? So we try to address that and try to make it very clear that the dressing goes on the wound and the bandage holds the dressing in place. Again, before doing a bandage, always check CSM, circulation, sensation, and motion. And this is before and after doing the bandaging, because you want to make sure that you don't reduce anything. You don't reduce circulation, sensation, or motion when you apply the bandaging. We're looking for new photos, may have to take them ourselves to replace these, and it's just a copyright issue. But this is the same stuff that we've done that we've had all along in how to dress a wound. Clean it, pull stuff out if need be, dab it, dress it, secure the dressing, and then how to apply a roller bandage. Here the bandage is correct in that it's unrolling from the bottom. It's unrolling from the side of the roll nearest the patient. Here we have to replace some screens, some videos, because the top one has the bandage upside down. So we will replace that, just like the second one here. The bandage is upside down, the roll. Impaled objects. I don't think anything here has changed. It's don't attempt to remove the impaled object, but stabilize it, immobilize the body part, and control the bleeding. Going into emergency bandages, the Israeli bandage. Lately, or the last few years, we've talked about them in La Miranda. The rest of the county still hasn't had them, had the instruction in them. So we're adding it to the whole county slide deck. And we've never had photos before of the sequence and putting it together. So this is, those are Julie's gloved hands in there, and one of our La Miranda CERT members is moulaged, so he's the victim. So we did a series of photos to show how to apply an Israeli bandage. Treating amputations. Again, we've covered this in the past. The only thing new here is that I did a new series of photographs to show the sequence of the severed finger, wrapping it, putting it in a Ziploc, and then putting the Ziploc into a bag of ice and putting the name, the date and time on, so that it can go to the hospital and carry all the data with it. We're getting more into signs of infection. We haven't had this in the past. Telling what the signs are, the swelling, the pain. And we want the CERT member to outline, as you see the felt tip mark, the outline, you outline the red with a marker and put the date and time where the infection had spread to that point, so that if it takes a day to or several hours to get to the next level of care, the infection may have moved beyond that line. So you want to be able to tell the rate of spread of infection by having a marker designated line of date and time. Tenderness, swelling, loss of hand. I can't read the title up there, but something about bones, muscles, and joints. Again, check CSM and immobilize. Going into more detail about what's the difference between a strain and a sprain. So here's a strain with the tear of the muscle or tendon. And the sprain is the stretching or tearing of ligaments. We don't really need to know the difference, except it's good to know what we're dealing with, but we treat them the same way. Check CSM again. Use the Rice mnemonic. We haven't used the Rice mnemonic in the past that I remember. Rest, ice, compression, elevation. So we've added that mnemonic. Dislocation. Becky, I see you out there. Did you talk about dislocations when you were teaching? Well, I didn't hear her, so, okay. We didn't have much in the slide deck about dislocation, so we're just talking about it now as don't relocate it, check CSM before and after splinting, just splint it and leave it alone and get it to more advanced care. Fractures, all new illustrations on the fractures, closed, non-displaced, displaced, and open. And then what you do for them. For an open fracture, the dressing, the protocol here has not changed. We've just changed the illustrations, and yeah, that's it. Doing types of splints and anatomical, soft and rigid. Again, thank you to Julie with the blue gloves and Jose, our victim. Splinting guidelines. I don't think there's anything here that has changed. We have splinted the same way all the time, but we're just stressing the CSM before and after the splinting. And how to sling. We haven't had a picture series before of how to tie the slings, and it's been confusing to people of what part goes under the arm, what goes over, so forth. How do you tie things? So we did a series of photos showing the knot in the 90-degree angle, creating a pocket for the elbow, and then positioning that.
Hey, Duncan, Patty here.
Yeah.
Wait, with the picture, go back one. Do you think we better see how the point is on the left, but Jose, his elbow's on the right?
Good point. I will flip the two triangular photos.
Yeah, great. Thanks.
Okay. So here it is with the pocket at Jose's elbow, so his elbow won't slip out, and showing the bow at the side of the neck, so it's not over the spinal cord. And then talking about tying a binder around. We probably should have photographed a binder, but we didn't. Is it important? Should we go back and rephotograph?
It's important if you're moving the victim or stabilizing, but we can add that in. I mean, we can just tell them, but if you want to keep it all consistent, sure, take another picture.
Okay, well, it would mean reshooting the sequence, but that's not a big deal. But okay,
Yeah.
so we can do that.
Hey, Duncan, there's also some debate, as there always is, as to whether or not that arm should be elevated towards the shoulder a little bit, as opposed to being just horizontal as it is now, to reduce some of the swelling. But I know there's all kinds of debate about that, but I'm putting it out there because that is one of the recommended things you do in this splint.
Put the hand slightly elevated.
Yeah, you take his hand. I've noticed his arm right now is basically horizontal.
Correct.
You take the injured thing and you move it up towards the shoulder to reduce a little bit of blood flow to the fingers and reduce the swelling. That's what I've gotten in the latest medical courses I've taken, but I'm sure there's some people who might disagree. But
Oh,
I concur.
Yeah.
So,
am I being clear?
oh, absolutely. Like that?
Yep.
Okay. We will redo those photos. So then we go into practice. Bites and stings. Again, the formatting on this is all over the place, but the information's there. We talk about anaphylaxis. Hypothermia. I don't think we've changed anything in the hypothermia. In treating them. New video or new photos for frostbite. treating the frostbite has changed in the recommendation just slightly. Immersing it in warm water until the tissue is soft red or purple. That's new. Warm slowly, don't refreeze, don't massage, and wrap the body part in bulky, dry, sterile dressing. Hypothermia, we reworked a little bit, discussing heat cramps, exhaustion, and heat stroke, and noting that when you're wearing PPEs, you have to be very cautious that you don't get hyperthermia, because PPEs can get pretty hot. Here I reordered things so that they went straight across. Like the sweating is now the top thing on both. That's an easy way to tell if they're in heat exhaustion versus heat stroke. They're sweating if they're in heat exhaustion. There's no sweat if they're in heat stroke. So I put those just straight across line for line. Before, the no sweating was down a few lines. So everything is straight comparison. Cold, pale, and clammy for heat exhaustion versus a high temperature for heat stroke. Fast, weak pulse versus fast, strong pulse, so forth. And what to do about hyperthermia. Cooling the body. Wes, what's your feeling for how much should be cooled at once?
Well, you're basically cooking the brain. So the quicker you can get them cooler, the better off you are. I mean, without, dropping them in a, ice cold pond, of course.
Right.
But anything short of that, go for it.
Go for the whole body.
Yeah.
Okay.
That are, under the armpits, the usual places where you have exposed, you're closer to an artery. You want to cool those first because it's going to cool down the body the fastest. But, that's getting a little bit surgical, right? You might as well just cool them down as best you can, as fast as you can, anywhere you can.
Right. Okay. Sports drink, not salt tablets. And you give them anything by mouth, you give them slowly enough to avoid vomiting. No food or drink, that we've had in the past. If the heat exhaustion doesn't improve in 15 to 20 minutes, you triage them as red. We should remove the immediate there. It's no longer red/immediate because it's in Contra Costa, it's just red. Patient requires immediate transport. And for our people, our CERTs, anyone who's going to be returning to work, we want them to stay out of the heat for a day or so. I don't know why the person who was revising this put a day in quotes, but they need to stay out of the heat until they're sufficiently recovered to be able to go back and work.
Hey, Duncan, one thing that we just saw in a recent research, and it sounds obvious, but it's not on these slides, and that is whatever cause of these temperature injuries that you've got, the number one thing is to remove the person from the environment where they got the injury to begin with, right?
First bullet.
Oh, did I move that? Okay, got it. Sorry.
Okay. We go into questions and we have takeaways. Boy, I did that in an hour, not an hour and a half. Having never gone through that in this mode before, I didn't know how long it would take. Do we have any questions?
Okay, it's Diana. I'll turn my camera on too.
Yes, Diana.
When I took first aid from Red Cross, we talked about bleeding and then breathing, because if the guy is spurting, it's not the time to worry about whether he's breathing or not. You need to fix that first. So I'm just questioning, doing two opening the airways before you fix that spurting thing. Or, serious bleeding.
Right. And the current protocol is BAC.
Yeah.
So I will go back and look at that.
It's just a question because, they said they'd bleed out faster. You got 4 minutes if you're not breathing, but you got less time if you're bleeding out.
Hey, Duncan?
Yeah.
Gordon here.
Yeah.
Oh, okay. After we have an opportunity, as we've just done, to look this over, and those that have, many years of experience in this, what we're doing here, when what did you use the term, the consortium, the Contra Costa County, coalition.
Coalition, yes.
When the coalition meets and they bring together the comments and suggestions like you're doing, I presume you're doing that. And is there someone in the medical field who's an ER physician or a surgical or a nurse practitioner or somebody that's in that group that can go over if they, or make comment if they see something that isn't quite right by them in the medical field? Because we've heard some suggestions here tonight, which may be perfectly all right, but rather than just, let it pass and not question it, should somebody be there in this group of the coalition that has that medical experience?
Okay, the primary person who went through and made all the changes to the medical units is a retired MD. And
Okay.
keeps her license active. So this is all medically produced, and
Approved.
then it will be reviewed by the, as I remember the commitment, it was the medical director for San Ramon Valley Fire's ambulance and EMTs will review it once I'm done with it.
Okay, great. Thank you.
May I make a comment on that?
Yes.
Recommendations tend to change over a period of time, and physicians notoriously have differences of opinion. So you will not necessarily get a unanimous opinion from people who have a lot of medical training. So eventually you'll just pick one of the suggestions and stick with that.
Thank you, Gene. Yes, we've found that medical people from different organizations who should all be coordinating their knowledge, that is FEMA, NIH, CDC, so forth, they come up with very different opinions. And the MD who put all of this together as source for me to finalize, to push it together. Just a moment, she's outside. She's very active in Wilderness Medical Society. So she has a different point of view than some of the other people, and feels that some of the recommendations from FEMA would actually kill people. So we're taking more of the Wilderness Medical and the CDC view rather than FEMA when they disagree.
You know, Duncan, in my 2 cents, I found that if this is emergency medicine, otherwise we call it dirt medicine, right? You're far better off giving it to reviewed by the COCO or ceremonial fire guys who run the rigs, who do this every day, all day, emergency medicine, as opposed to a doctor in an ER. They have quite a bit different experience. And so, for what it's worth category.
Well, we used to teach this as jungle medicine, and that's pretty much what it was coming out of the jungle. But whatever the terminology, we just want to make sure that whatever we are telling students is the correct thing to do. We don't want to give anybody a bum steer on any of this information. And I think 99.9% of it is all very, very good and well put together. But, you know, it's always that one time that something happens, they go, well, you know, they told me to do this, or we didn't do that. So it's just kind of a reaction, a protective reaction on my part.
Absolutely, and we thank you for voicing that. We have a lot of medical opinions, and they're frequently different. But as long as we teach them something that is going to do no harm and hopefully help, then I think we're covered. We want to teach them the best that we can. But things change too. Any more comments, Jim? Any of the active instructors? Do you have anything to add?
Can't hear you.
Yeah, Gordon, you're not muted.
Oh, okay. Hold on. My bad.
Okay. Well, if I don't hear any more comments, then I will let you all get back to your evenings. Our monthly meeting next month will be a presentation by MOFD. It's their start of the fire season presentation. I don't know what Dave's going to be talking about, but he has requested that he get the stage next meeting. So it will be an MOFD, probably Winokur, Rain, and Jeff Isaacs is my guess as to the speaker panel, and we'll hear from fire. Okay.
Is that going to be on the 6th? Is that going to be on June 6th by chance?
No, it's second Monday.
Second. Oh, okay. Okay, good. All right. Thank you.
Okay, so second Monday next month, and the newsletter will come out a week to 2 weeks beforehand to let you know what the meeting is. This presentation, this meeting recording will be up on the website by Wednesday morning. Thank you all for coming. Have a good
Have a good evening, everybody.
Good night, all.